Hi, everyone. My name is Ben Green. I am the Senior Vice President of Services here at AliveCore. Today, I'm really excited to be talking with Professor Matt Reed uh, of the University of Edinburgh. It's a it's a really great opportunity to discuss with Matt a really pivotal study that he led now over 5 years ago, which is amazing, but it is still very much relevant to healthcare discussions today. So as we look to the trial and how that trial led to guidance in the literature, it's hopefully going to be a great conversation today here with Professor Reed. So the study that we're talking about today is the IPED study. It's the investigation of palpitations in the emergency room. As I mentioned, this study occurred and was published in 2019. However, many of the concepts that we'll be discussing today are very relevant today, and we're going to go into that in much detail today with Professor Reed. Professor Reed, like I said, I'm incredibly fortunate to be able to talk with him today. He is a very prolific researcher and an emergency medicine physician. As I noted, professor of medicine at the University of Edinburgh. He is the head of research at the Royal College of Emergency Medicine. He also is the UK representative for the European Society for Emergency Medicine Research Committee. He's a consultant and NRS career researcher in emergency medicine at NHS Lothian, and many more other things. It's really a distinguished resume. So Matt, pleasure to have you, and thanks for joining today.
Thanks, Ben, and yeah, thanks for having me on and giving me a chance to talk about the IPED study.
Fantastic. Well, I described some of the roles that you currently hold, but I'd love to hear just from you a bit more about your background. How you got to where you are today. Your passion for research obviously is very evident. And tell us a little bit about your story.
Sure, yes. So I'm a consultant in emergency medicine in Edinburgh, as you said. I've been up in Edinburgh now for over 20 years, and I came up here to do my training in emergency medicine. And towards the end of my training, I started to get the bug for academic emergency medicine. It's probably fair to say that emergency medicine as an academic specialty was had had done an awful lot of really good things over the last 30, 40 years, but we're probably still more of a fledgling specialty in terms of academia at that time. And the improvement and the steps we've made over the last 20 years have been absolutely amazing. But so I got the bug for research then, and I did an MD towards the end of my emergency medicine training. So now I'm lucky enough to have about half of my time when I do research. So I work as a professor of emergency medicine and do a lot of work in with our research group, which I lead. And as with most emergency medicine research groups, we do research into some specific areas where we have some specific interests. But as emergency physicians, we tend to sort of find a lot of things interesting and can't help ourselves getting involved in all different types of research questions. So our group cover a whole lot of emergency medicine presentations. I specialize a little bit more in cardiovascular emergency medicine, but essentially we research the whole gamut of emergency medicine presentations, anything that's important to patients and to clinicians. And I also work clinically, so the other half of my time I work on the shop floor, seeing patients as a consultant in the emergency department. So yeah, so that's how I do spend my day job.
Yeah. So you're a busy man, to put it lightly. And from the, I guess from the perspective of doing research, you're certainly doing a big part to advance emergency medicine as a specialty, especially as it relates to the research that you and your teams have developed over the years. I did a Google Scholar search, and I think there's over 150 publications that you are an author on, and the range of clinical areas is also pretty remarkable. Things obviously like syncope, which seems to be a very strong area of interest, but bleeding, acute aortic syndrome, HIV screening, airway assessment, COPD. Really, it runs the gamut of emergency medicine scenarios, which is really fantastic in terms of what you're advancing. The iPad study, if we kind of focus on that, was focused on palpitations and pre-syncope. So I know syncope is a big area of interest of yours. What really led you to look at this specific category? People that come to the ER with palpitations or pre-syncope, and why was this an area of interest for you?
Sure, yes. So I've been interested in syncope since about 2011, 2012, or even before that, actually, when I did a lot of work about risk stratification and use of biomarkers, and still continuing a lot of that work. But the interest in palpitations sort of came around about in about 2015, and it came about through, as most research ideas do, through my clinical work. So I remember now it was a Friday afternoon, and I'd seen a couple of patients in the emergency department, and they both presented with palpitations at work, and they both had settled by the time they came to the emergency department. We worked them up; their ECGs were normal, and I remember being very frustrated by the fact that we couldn't offer them anything at that point. Uh, Other than to represent should they get their palpitations again, um, or to phone an ambulance, and the ambulances could record an ECG tracing, but that wasn't probably the best use of an ambulance, or to the GP, but GPs have less access to ECGs now, and this may have happened in the evening or out of hours, for example. So I went home that evening, and I had a couple of friends staying with me that evening, and they were off to do the OM, this something called the Original Mountain Marathon. That's
Hmm.
a sort of a running event in the wild in the mountains of Scotland. So they were staying
Okay.
with me beforehand, and they had their gym watches on, so they were recording their pulse rate
Yeah.
only at that point. And it got me thinking: is there anything out there like this that includes an ECG? Um, that patients could record their ECG, the actual electrical rhythm of their heart, while they're having their palpitations.
Hmm.
So I declined their kind offer to join them to run 100 miles that weekend in the rain, and instead did some Google research and stumbled across the AliveCore device.
Hmm.
And I thought, can we use this in our emergency department? Can we use this in our palpitation patients? So yeah, Monday morning, got down to finding out a bit more about it, writing a grant, and a few months later, found out we were successful to get a grant to be able to run a study.
Wow. I mean, we've heard a lot of stories like that where people that are doing the activities or other things, they're obviously monitoring themselves, not just for EKGs, but for other things, and now bringing that into healthcare, which is what you've done here, is I think is really driving a lot of great changes in healthcare. Can you speak about maybe some of those challenges you mentioned? If people come into the ED, they're not having, that rhythm abnormality at the time. They had palpitations, but once they get there, you're not able to pick it up. What are some of the options that you had maybe prior to the study, to try and figure out what's going on with those patients?
Absolutely, yeah. So first of all, I suppose it's important to define the specific clinical problem that we want to solve here. So, um, and that's about in palpitations, it's about capturing an ECG symptom correlation. So we need to obtain an ECG trace that's happening while the patient is having their palpitations. Um, and we also want to do that in syncope as well. But the problem with syncope is the patient has blacked out,
Hmm.
has are unconscious. So we have to rely on continuous monitoring devices to be able to try and capture that rhythm in syncope. But with palpitations, the common the common causes, if they are a cardiac cause, are atrial fibrillation, atrial flutter, and SVTs. And patients, most of the time, are conscious, so they're able actually to be able to take an ECG themselves. So we can use something like an event recorder, which is where the patient actually starts the device, starts the recording themselves. So it makes it a little bit easier to be able to capture that. And traditionally, previous to the iPad study, these patients would have what's called a 24-hour tape, where they were fitted with it's an old-fashioned Walkman sort of tape recorder device with lots and lots of leads, and they would wear this for 24 hours. But very, very rarely would they have the episode of palpitation during that 24-hour period when they were wearing the device. So pickup rate was really, really poor. Um, so we really need something that the patient can, when they're out and about, they're doing the shopping in the supermarket, for example, their episode of palpitations come on, which may just be short-lived, may just last 20 minutes. Um, we need something that's able to capture their ECG during that moment.
Hmm. And what's, I guess, really interesting here as well is that this study came out of the emergency room where in a lot of situations where a patient would come in, maybe they wouldn't get diagnosed, like you said, they're not having the symptoms or that EKG trace is normal at the time, but then they're maybe sent back to their GP or they're maybe referred on to cardiology for that evaluation. Here with the iPad study, the emergency room and the physicians in the emergency room were the ones that initiated that follow up surveillance, that follow up diagnosis. So, can you kind of speak to the objectives and why you went about that route, where the emergency room was really the clinician responsible for following this patient over what turned out to be 90 days in this study?
Yeah, sure. So, um, well, there are obviously different models of how we can use this intervention in healthcare. Um, and our cardiologists at the time also were receiving referrals from patients who had palpitations to be seen in their clinic. But um, and uh, I believe some at that point had were aware of the Alive Core device and the Kardia device, and were recommending it to some patients. But um, we see a large number of patients coming. So it's our palpitations is last year our 11th top presentation, so just misses out the top 10.
Mm-hmm.
We see more than 2,000 patients a year come into the emergency department. So that's a lot of patients, and
Wow.
it's about 300,000 patients that come to emergency departments up and down the UK every year. So it's a problem, and that's an important thing. It's a problem we need to
Mm-hmm.
solve in the emergency department.
Yep.
Waiting times for outpatients in cardiology are long um, in the UK, and certainly for palpitations, it's maybe seen as something that's not due to an immediately life-threatening arrhythmia. The patient's not going to have a cardiac arrest, um, and it's difficult to get an early appointment. And also a lot of the underlying causes are benign, so they're not actually cardiac, which
Mm-hmm.
we can talk about with the results of the iPad study.
Yeah.
So it's really a problem that's focused within the emergency department. And a patient's sitting at home and they get their palpitations, they feel pretty rubbish with them. And
Mm-hmm.
so they come to the emergency department, and it means that so we need to find a way to be able to offer something to them rather than just sending them away with nothing else to offer apart from um, uh, an outpatient appointment in several months' time and
Yeah.
advice to come back if it happens again.
Yeah. Yeah. Well, this really kind of goes into the design of the study, and can you speak to kind of how how you designed it, why you designed it as such, what were the primary outcomes you were looking to measure, and then some of the secondary outcomes that resulted as well.
Yeah, definitely. So obviously we found the Kardia mobile, and we decided that this was going to be a device that was potentially going to be sort of game changing in these patients. Um, it was easy to use. It didn't have all the leads. People could carry it around with them all the time. They could put it in their bags, or in their wallet, in their purse, for example, in their handbag. So they would have it with them. It's nice and small. We already knew from doing some uh, literature review that the sensitivity was extremely good. There was little in the way of noise and artifacts, um, and it was good at recording an ECG. It's then how can we then use that um, to investigate our palpitations patients. So we weren't studying the effectiveness of the device recording ECG. There was also already a lot of research out there showing
Mhm.
it was very good at that. So um, we've in the UK we've got the benefit of a really good research network. So because emergency medicine is reasonably small, most academics from the emergency department and clinicians know each other. We've got about 200 major EDs, and a lot are research active, but we've also got a research network set up by the NIHR, which means that around this time that it was easier to enable sites to join up with the study. So uh, we wrote a protocol and enlisted the help of 10 other emergency departments across the UK. We could have had many others who were interested in taking part, but we only needed 10 when we worked out what effect size we were looking for, what our main research question was. So fairly quickly, we had 10 sites signed up to take part in the study. And we decided that the best method of doing this was to do a trial. Trials tend to cost a little bit more money and can be harder to set up. There's a little bit more paperwork involved in setting up a randomized trial, but they are the gold standard of research. So if we really wanted to investigate this question, we needed to ask a question and randomize patients to one of the two groups, one of whom we would give the intervention, which in this case was using the Kardia mobile alongside the standard care they would get. And in our control standard care group, these patients just got standard care, whatever that was in the department that they were coming to.
I think how you've set it up, as you mentioned, is the gold standard, preference and way, in a randomized fashion, multi-center, multi-site, getting that diversity of patients um, and obviously the coordination of this study across 10 sites. I can imagine could be a challenge. How did you deal with coordinating so each of the sites were able to initiate that intervention appropriately?
Yeah, absolutely. So that there were a few things that were on our side here, actually. The fact that uh, mostly nowadays, you can't really do a trial without involving a trials unit. But 10 years ago, we were actually able to run the trial within our research group itself. We've got an excellent group with a little bit of experience in running trials at that time. So one of our research nurses took on the role of being the trial manager, coordinating, setting up all the sites. And then, in fact, we ran this as a researcher-led trial. So it wasn't a commercial trial funded itself by LiveCore. It was funded by the British Heart Foundation and also by Chest, Heart and Stroke Scotland. So we were able to purchase devices for our patients through a research grant, which allowed us to be very independent um, and to be able to ask the specific research questions that we felt were most important here. Um, these things are never easy. So
Mhm.
setting up a trial of this size, um, recruiting the patients that we did, but the team were amazing, and we managed to set up the trial, recruit all the patients, and actually do it in the time frame that we plan to, which again is quite unusual for trials.
Yeah, yeah. Well, kudos to you and your team for that massive coordination effort. And these were hundreds of patients that went through went through the study, and can you speak to sort of maybe the size of each population, the control and the intervention group, and then what were those outcomes that you were looking for over the next 90 days, post ED visit?
Yeah, sure. So we recruited uh, I think it was about 250 odd patients, um, and yeah, 200 and yeah, 40, I think it was, um, and the uh, the main aim was to so, look at these patients for 90 days because, as I said before, 24 hours isn't enough to be able to pick up the underlying arrhythmia. So we wanted to give the patient a good opportunity to be able to capture the underlying cause. So sometimes with palpitations, patient will have an episode. They might not have another episode for another month or so. They may have several over the next week.
Mhm.
But we wanted to um, plan it so that we had the maximum opportunity during that time to pick up the symptomatic rhythm. So our primary outcome was a symptomatic rhythm detection at 90 days in the intervention group compared to the standard care group. So that was our primary outcome. So we wanted to see whether we could pick up more patients in the intervention group who managed to record an ECG while they were having symptoms. Um, and that's important because not only does it show if the patient's recording an abnormal ECG while they're having symptoms, um, we can obviously pick up the cardiac arrhythmia. But also, if a patient has several episodes of palpitations and we record sinus rhythm during that or sinus tachycardia, which is where obviously the heart rhythm is normal but just going fast for some reason, or ectopic beats, which is what a lot of patients with palpitations have, where they have a missed beat and then the next beat's a much firmer beat that they become aware of, and that's fairly normal. We all have those, 2 or 3 times a minute, but some people can have them more, become more aware of them. But if we can capture that as well, that's just as important because we've ruled out it being a cardiac cause because they're having their symptoms and we've shown that the ECG doesn't show anything concerning during that.
Mhm.
So that was our primary outcome. We were also looking for the time it took us to pick up that ECG symptom correlation. Um, we wanted to look at the time it took to pick up cardiac causes. Um, and as well, we had patient public involvement as well with the studies, and it was very important. We looked at patient satisfaction um, and how compliant were they with the monitor. So did they just take it, leave it at home, back on the back of the sofa, and then didn't actually use it for the next 90
Mhm.
days? So it's very important that we looked at compliance. We also looked at cost effectiveness. Again, that's really important if we're going to then embed an intervention into healthcare that we are able to show how much it costs and any um, health economics and any cost benefit that um, the intervention group might have over our standard care group. Um, we also looked at death and major adverse cardiac events, although they are very rare in this patient group, but obviously very important that we look at that as well. And I think the reason why we managed to recruit as many patients we did so quickly is that it was an easy sell to patients because we were
Mhm.
actually offering them something that wasn't on offer out with the trial. So they could see the benefits of it. And it was probably one of the easiest trials to recruit to. So patients overwhelmingly were keen to take part in the study. In fact, the main problem was once you'd randomized patients, which is obviously assigning patients to one of the two groups through the equivalent of tossing a coin. Um, half of the patients you had to disappoint them by saying, "Oh, unfortunately, you're in the standard care arm." you're still really important to us. So we want to see what happens to you over the next 90 days. And lots of these patients got followed up in standard care ways with 24-hour tapes and things. So they were
Mhm.
very important to us. But there was always a sense of disappointment with the patient when they weren't
Yeah,
randomized to the intervention group.
yeah. And I imagine, a lot of these patients, who come in with palpitations, they're anxious. They don't know what's going on. Obviously, they're coming to the emergency room for a reason. I also found it interesting that the average age of the population was around 40. So a much younger population than I think some people would expect. And a population, obviously, that they want to get to the bottom of what's going on. So and the outcomes that you were intending to determine, I think really, helped to drive, that, like you said, a symptomatic rhythm, even if it was normal, I think could be very helpful to help allay concerns and anxiety for some folks.
Yeah,
Um,
definitely. I mean, SVT is something that affects all age groups. Um,
mhm,
so obviously, we see patients from the whole age spectrum. Atrial fibrillation is obviously more frequent as you get older, and can potentially increase your risk for stroke if you have atrial fibrillation. So it is important we pick it up in patients as well. But yeah, obviously, as you get to the older age group, there's more chance of detecting AFs.
yeah,
But the SVT can be in any age group, as you'll know.
yeah.